Across the country, hospital administrators, doctors and public officials are pleading for ventilators, as the spread of coronavirus is making growing numbers of patients dependent on the machines that pump oxygen into their lungs to keep them alive. But while hospitals and healthcare workers grapple with the grim reality that they may soon be forced to deny potentially life-saving treatments to certain patients due to a lack of supplies, some doctors are raising questions about how ventilators are currently being used on coronavirus patients, and whether they may actually be doing more harm than good. Early reporting on coronavirus deaths from China, Italy and the US show that more than half, and as many as 2/3, of COVID-19 patients who are placed on ventilators don't survive. What we're doing now is not working. And I think making the same mistake over and over is a sign of stupidity. Dr. Paul Marik told Yahoo News. If it's not working, we've got to look for something else. Marik is promoting a treatment of his own devising. A combination of corticosteroids and high-dose ascorbic acid, or vitamin C as a first-line therapy for patients hospitalized with COVID-19. Marik's theory is based on an idea that is becoming widespread among researchers, that the cause of death for a significant number of COVID-19 patients, especially younger ones, is severe inflammation of the lungs resulting from an overly vigorous immune system response. By administering anti-inflammatory drugs early and regularly after a patient is admitted to the emergency room, Marik believes he can prevent this complication, known as a cytokine storm. In those cases, it's not the virus that's killing the host. It's the host's response to the virus, said Marik. Coronavirus is highly contagious and can cause fatal disease in some patients. But immune reactions to the infection varies dramatically from person to person. People who are doing fine don't need steroids. It's the people who get sick from the storm. Marik said, corticosteroids are really effective in downregulating that storm. In addition to early anti-inflammatory treatment, the protocol followed by Marik and his colleagues includes alternatives to using a ventilator, a machine that delivers oxygen under pressure directly into the trachea by means of a tube inserted through the mouth. This requires deep sedation and prevents the patient from talking. He favors a technique called high-flow nasal cannula therapy, which delivers humidified and heated oxygen through nostril tubes, a less invasive procedure than intubation, and suggests positioning the patient on the stomach to improve oxygenation. Cameron Kyle Seidel, an emergency medicine doctor at Maimonides Medical Center in Brooklyn. Now believes the treatment method being widely adopted for those suffering from coronavirus-induced lung disease is based on a false paradigm. I fear, he said, that using ventilators to increase pressure on the lungs in order to open them up is actually doing more harm than good, and that the pressure we are providing to lungs, we may be providing to lungs that cannot take it, and that the ARDS that we are seeing may be nothing more than lung injury caused by the ventilator. While doctors like Marik and Kyle Seidel are pushing to change the way ventilators are used to treat coronavirus, others are drawing attention to the possible long-term physical and neurological damage caused by the current method of treatment. For many COVID-19 patients who must be put into a medically induced coma before being placed on a ventilator, the treatment itself can cause significant damage to the heart, kidneys or brain that may be permanent, or even fatal. Even among the COVID-19 patients who are ventilated and then discharged from the intensive care unit, some have died within days from heart damage. For those who survive, the amount of sedation needed for COVID-19 patients can cause profound complications, damaging muscles and nerves, making it hard for those who survive to walk, move or even think as well as they did before they became ill. Many spend most of their recovery time in a rehabilitation center, and older patients often never go home. They live out their days bedbound, at higher risk of recurrent infections, bed sores and trips back to the hospital. Dr. Catherine Dreger, a clinical assistant professor of medicine at Georgetown University, clarified that she is not suggesting we shouldn't use ventilators to try to save people, but rather that Americans should consider these facts and figure out what they would want for themselves and their loved ones now, before it's too late.